So over the last year, Jen and I have really worked hard with a lot of different resources to pull together a lot of different things we were looking for. So we knew a lot of the basics of what does autism look like, but we wanted to dig a little deeper into that. So some of the objectives we have tonight, the first one is going to be recognizing what those red flags look like, and realizing that they're not in isolation. So if you see one thing, it's not like an alarming, like, oh my gosh, this child has autism, but what else comes along with that to make you start to question maybe there's a little bit more going on. And we're also going to kind of help you think about how you collect what you're observing. So when you're seeing different behaviors of children, in different settings, across the same setting, with different people, how are you organizing all of those things and pulling them together? How do you then go and make an appropriate referral for a child based on their age, based on what they need? And then what does it look like if the child is under 3 and has been in early intervention? What does life after early intervention kind of look like, and what can we do for them even after age 3 to set them up in a good direction? Can I get it? How many of you are parents? How many are professionals working with younger children? And then, what else? Did I miss? Grandparents? Okay. Okay.
Anyone have children in early intervention right now or have gone through early intervention?
Okay, great, thank you. All right. So we're going to start with the real basic just definition of what autism is, and this is according to, the thank you, help me.
The
DSM, thank you, DSM-10. So it's a biologically based developmental disorder that affects children's social interactions, their play and language, and will sometimes be repetitive behaviors. Does that seem like what you kind of have in your mind of what it is? Okay. So we recently looked, and in 2013, what they've said is that 1 out of every 88 children is being identified with an autism spectrum disorder. So we know that there is a range of what that can look like, right? So they call it a spectrum because it can look very different from here to here. So some children you will look at, we'll go into a home, and within a few minutes we've already got some things popping up and we're thinking, oh, okay, there's some things going on, we need to dig a little deeper and figure out this. Sometimes you're in there for months and you start to see little things here and there, and they start to add up, and then you start to think maybe there's something else. And that can be that range of what's going on. So what can it look like? So first of all, it can look like a deficit in social communication and social interactions across context that isn't accounted for by just a general developmental delay, and it can come across in the following ways. So for a child to get a diagnosis, according to the DSM-10, they've got to meet criteria from each of these following things for an actual diagnosis, okay? So the first one is the deficit in social and emotional reciprocity, and that can range kind of all over the place. So it could be an abnormal social approach and failure of normal back and forth conversation. So a parent is talking to the child and talking to the child and talking to the child, child's not responding back. Or when they are responding back, it's not an appropriate response back. A reduced sharing of interest, emotions, or affect. So some kids have more of what we kind of call like a flat affect, so they're not really showing different range of emotions. Or they could also have the opposite end where their emotions go from very low to very high very quickly. So something could bother them, and all of a sudden the next thing you know, they're throwing themselves on the floor, they're kicking, they're screaming, and there's really no consoling them. So there's definitely two opposite sides of that. And it also is the failure to initiate or respond to social interaction. So one of our staff mentioned earlier, you're sitting and you're doing that puzzle, right, with a child, and they're really intent on the puzzle, and they're like, doggy, and they stick their hand up for the next piece. Kitty, and they stick their hand up for the next piece, but there's no interaction with that person. They know you have that puzzle piece, but there's no eye contact. If you hold it for a few seconds, they're still not looking up to get it from you. So kind of recognizing what they're doing is they're really focusing, but there's really no interaction between you and that other person that's there. So also it's a deficit in non-communicative behaviors used for social interaction. So poorly integrated verbal and nonverbal communication. So if a child isn't speaking, a lot of times what they can do is use their body language to tell you a lot, I've had families say to me, I go into the house and she's like, well, she doesn't really need to talk because she tells me everything I need to know by pointing and gesturing and showing me what she needs. I want her to talk, but I am communicating. This would look different because you're not going to get that other communication. You're not getting a substitute for the nonverbal language. You're getting nothing. So they might just stand at the refrigerator because they want a drink, but you're not getting a point. If you're asking of a choice of two things, you're not getting a, yes, I want this one, or pointing at the one they want, or even grabbing the one they want. It could be abnormalities in eye contact and body language. So it's, you go to snuggle up with the child and most children would kind of lean in. Maybe that's not happening. Maybe they look at you occasionally, but it's not in an intentional way. So it's not to get your attention, or it's not to join in your conversation or join in your play. It's just to kind of look around, yep, you're there, and that's the end of it. That's the end of the contact with the two people. A deficit in understanding and use of gestures. So you might be pointing like, get your shoes, and they're still not following what you're asking them to do. Total lack of facial expression and nonverbal communication. So again, none of that pointing, which is one of the key things we ask families. Like, so do they point to what they want? Do they gesture? So if they're not talking, what else are they doing to let you know what they need to get their needs met? And we're really not seeing anything. Any questions?
So continuing with what it can look like, deficits in developing, maintaining, and understanding relationships with some of the following. So difficulty adjusting behavior to various social situations. So think about, children who may tantrum, and there isn't any reason at the moment that they're actually tantruming. Think about being in a noisy crowd versus a quiet crowd, how children can react when they're around different crowds of people. What do those behaviors actually look like? And is there some type of, issue that had, preceded, but is it just abnormal in that way where it's like they're just tantruming, throwing themselves down on the floor, and like Casey said before, they're unconsolable at that moment. Difficulties in sharing imaginative play or in making friends. So thinking about children, typically in the toddler developmental stage, they do what we call parallel play. So children may play on the side of one another, sometimes occasionally interacting, glancing over, making some eye contact, sharing of toys, turn taking. You'll notice that there's difficulty in that or an absence of that altogether. And third, again, absence of interest in peers. So really just kind of playing beside someone, but really showing no interest in them or even acknowledging the fact that there's another child sitting with them trying to play with them. So restrictive, repetitive patterns of behavior, interests, or activities manifested by at least two of the following. So again, referencing back, like Casey said, to the DSM-10, the criteria have to happen in each of these different areas, and there has to be one in this particular area. They're saying that there needs to be two. So the first is stereotyped or repetitive motor movements, use of objects or speech such as simple motor repetition, lining up toys or flipping objects, echolalia, or idiosyncratic phrases that are unusual. So giving some kind of examples, the motor repetition when you see children who may be flapping, stimming, spinning, walking on their tiptoes, things like that would be considered simple motor repetition. The lining up of toys or flipping objects. So children you may see who, cars is a pretty typical one that we see, children who have a lot of cars and just consistently will line the cars up, move them back and forth, spin the wheels consistently. That's what's considered to be, the lining up of toys or flipping. The echolalia is an automatic repetition of another person's speech. So for example, when, walking in, if I would say, hi, Johnny, the exact response back to me would be, hi, Johnny, how are you today, Johnny? Repeating back to me, how are you today, Johnny? So realistically, repeating everything that is being said to them word for word back and forth. And the idiosyncratic, language with private meaning or meaning that only makes sense to people familiar with that phrase. So one of the examples is that something like Cheerios, which we know Cheerios are cereal, they would just call them circles. So a person who didn't know that child intimately, if they're out in school, let's say, and they know, they say to their parent, circles, 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 and they're getting really upset because they want circles, which to them means Cheerios, but that's just, something that they use at home with their families, or calling something like Pop-Tart squares. So it's, kind of like private meaning that they've had for things that they want, and then that's really hard for them to communicate to people who are not with them on a daily basis. So the next one is insistence on sameness and inflexible adherence to routines, ritualized patterns, and then verbal and nonverbal behaviors such as extreme distress with small changes, difficulties with transitions, rigid thinking patterns, greeting rituals, and the need to take the same route or eat the same food every day. So some of those examples, we know children who do have an adherence to routines, if you do something the same way every day at every time and you try to switch that routine, they're really going to have a meltdown because they cannot continue with themselves. Ritualized patterns, we find sometimes there are children who need to do things in the same order, the same way every day. Other things we've seen, using the same spoon, the same fork, and if you try to give them something different to substitute, again, behaviorally they're just going to have a meltdown because they really need to have it in the same way consistently. Difficulty with transitions, greeting rituals, and again, needing to take the same route or eat the same food every day. Trying to give, a child something different or going a different way, or the way you come into childcare, let's say, to drop off and you go a different way can cause extreme distress for them. The next one is highly restricted fixated interests that are abnormal in intensity or focus, such as strong attachment or preoccupation with unusual objects, excessively circumscribed boundaries of limits, and then perseverative interest. So some examples, as I talked about, using the same cup, the same spoon, really having a strong attachment to those particular things. And then being excessively circumscribed means a narrow focused interest on something they want, but they have continuous engagement with. The perseverative interest, again, giving an example of the toys, the wheels on a train or the wheels on a car, really having perseverating over the wheel spinning over and over, and that's how they have their play with it, even though that isn't functional. Yes?
So, like with the spoon, the cup, if you have the child and you know that, do you give them those same things every day? Or do you try to, like, as they get older, clearly things are not going to always be the same.
Yes, prescribed and circumscribed. I mean, I think for us in the early intervention population, it's really about what's going to work best for the child and what's going to work best for the family. So if you as a family at that point in time really don't want to cause distress for your child, distress for your family, you may have other children, you really are just going to keep on with the same cup and the same spoon at that particular stage in development, just because that's going to work what's best for you and your family. You obviously know as you move on in the stages of development, they're going to end up in childcare or preschool, kindergarten, elementary school, and then there may be different approaches that the school is going to tell you that they're going to do when it comes to snack time or lunchtime. But I think for the under 3 population, you really have to do what's best for you and your family and decide, is this really something that we really want to kind of shift and tackle, because it is going to cause excessive tantruming, meltdowns every time you try to switch something up. So you just have to decide really what's best. Okay? So again, continuing on with what it can look like, hyper or hyporeactivity to sensory input or unusual interest in sensory aspects of the environment. So some examples would be apparent indifference to pain or temperature. There are some children who, they'll say, he just has this really high tolerance for pain. Nothing seems to bother him. Getting hurt, they don't cry. That's what that really refers to in regards to the pain. Adverse response to specific sounds or textures. So thinking about those children who may be out and they hear really loud sounds, vacuum cleaners can be one of them, horns, and they're immediately putting their hands over their ears because they are having an adverse reaction to that sound. Another one is textures. Children who may have, we call them picky eaters, but it's really about the textures. The foods that we're giving them, they're really unable to adapt in their mouth, so they're really going to have that adverse reaction to those textures. Excessive smelling or touching of objects. So, children who may need to consistently smell things, lick things. You will see that a lot. Touching of objects, always having 2 objects in their hands at all times. And then lastly, visual fascination with lights or movement. So again, sometimes we think about, in observations, we see children who we have those like light up toys, and they'll have the toy on the floor, but really they're only focusing on the light that is flashing off of the walls, or the flashing of the different colors, or the different, colors and the shapes. They're not really using the toy functionally. They're just really having a visual fascination with the lights and the kind of what's coming and putting on the walls or on the floors, things like that.
So when you start to look at all those different things, again, we have, it's going to be a combination of those things that are happening. You want to see it in a bunch of different contexts. So it might be happening at school. You definitely want to talk to the providers at school and say, this is some of the things I've noticed. Please tell me what you've noticed, or have you noticed these things as well? Someone like my child who's with a different grandma, different days of the week, I would want to check in with them. And one of my mom comes to my house, my mother-in-law watches my daughter at her house. I would want to check in to see if it's happening in 2 different places. So, is she only making sure she's asking for this cup and spoon when she's at my house? Is she asking for it also at your house? And if you give her something else, what's happening when you do that? So you want to know what's going on in the home. The other thing that comes up when we start to think about this is, has something else happened in this child's life to affect their functioning? So sometimes a child that's gone through a traumatic event or is going through something where parents are getting divorced, or has seen something maybe years ago that parents didn't realize would have an effect, like we've seen it with domestic violence. They're not talking, or they're kind of very quiet, they're not doing a lot of that eye contact. Some of that is trauma, and sometimes it's really hard to tell the difference between what can be trauma and what can be an autism spectrum disorder. So you really want to make sure that you're kind of looking into those things and asking those questions. If it's your own child, like, has anything else happened? Have they seen anything that might have affected them down the line? What else is going on? So those are good conversations to have with the pediatrician, to say, I have concerns. These are my concerns. This is what I've observed. What do you think? Because it could be more than that. And we all know that kids have different diagnoses of different things all the time. So just because they have some of these things doesn't mean that it's an autism spectrum disorder either. There's other things that are out there too that kids are experiencing. One of the other things that we want to look at too is the child at risk for ASD? And when we say that, what we're saying is there another family member that has it? We definitely have seen siblings come in with it. So the older sibling we had a couple years ago, and now mom's calling because now she's seeing some of those same things in the younger sibling. So we definitely have seen that has been a link for us, at least in our early intervention program, that sometimes if another family member has it, someone else in the family is more prone to also have it. So once you've kind of collected those observations, you want to collect them over different times, different settings, different people, and you've kind of written down some of the things that, are going on, and you've interviewed other people, then you're able to kind of have a whole different perspective of what's going on, and then you've got a lot of information to be able to go to a pediatrician with, or to go to another professional with. We're going to show you just a couple of clips of some of the behaviors we talked about. We have one on the echolalia. We have one that shows a typical child and a child that is possibly on the autism spectrum, and it shows you separately and then side by side what they look like, so you can kind of see the differences. So we're just going to show you a couple of those. This will give you a few different ages to look at too.
You must say hi, Georgia. Hello. Give me a hug. Come here. Come here. I gotta tell you something. Hi. Give me a big hug. Oh. How are you? I'm fine. I'm fine. Good. Are you playing? I'm playing. Oh, it's cold, look.
So you can see everything she said, he just said back, and she was trying to give him the right responses so that he could learn what those were and give those ones back instead. So it's tough because he's repeating everything. So she's gonna, even the responses she gives, he's giving back the same things. But you can see it's not being used in a functional way. We've had some families say to us, well, the doctor said that she's at the age where she should be repeating everything. And it's like, right, if you say this is a cat, she should tell you it's a cat. She shouldn't be repeating the entire sentence back to you that you just said to her. So that can be tricky for families, that they're not, when you say like at 18 months they should be repeating everything, that's a hard thing because this is not the way you want to see it kind of be repeated back to you.
This one is lack of joint attention and some inappropriate language and communication.
That one doesn't have anything that pops. Let's go. It's for you, Evan. It's for you. Hello? Oh, you want to talk to Evan? Here you go.
So again, you can see he never glanced up at her, even though she was having a conversation with him. He never really picked up on it. She's showing and modeling for him how he should be playing with that toy, and he's just not able to do it. He's going to do his own thing with that. I swear this video disappears every time.
It does.
So this is a set of twins.
Yeah, it fell off. That's right. Here it is. Uh-oh. No! Push. Good boy. Ready, set, go! You can push. No, stay here. Stay here. Go! Stop. No. Go! Here it is. Take the tree. Stay up here, please. Push. Good boy. Ready, set, go! You can push. Yeah, it fell down.
It's really interesting when you see the two of them together. Like when I watched it the first time, I had to rewatch it because even the first child, I was like, I don't even know if he looked at mom the first time she was playing. But when I watched it again, he was really paying attention to her and looking up. And if you notice with the second child, the brother even walked behind him. And the first time I watched it, I thought, oh, he did glance over to see if he was there, but he really didn't. When I watched it again, I realized he was just trying to get down that way. He wasn't even looking over that way. So it was interesting to watch it separately, but when you watch them together, you could really start to see the difference. So some kids you would say, well, he just wasn't interested in that. He just didn't want to play. But most children would have words for that, like all done, want to get down, things like that, where he just really wasn't even sure what was going on. So some of the things you would be looking for is that back and forth play. That's that reciprocal play that goes back and forth. That's not happening. He's not returning what she's doing. He wasn't checking in with her. She was getting down tried to get down several times within a couple seconds. So he was just like, no, it's not like he was just uninterested. He really wasn't even aware of what was happening there. So any questions on any of the videos? So we will give you, in the PowerPoint, there's a link to a lot of those videos. So it goes through a bunch of different things. They're really good videos and they're quick, as you can see. So if you wanted to watch a whole bunch of them, it goes through a bunch of different ages of children, which is great. It does go up to, I think, 5 or 6 years old.
And it does give some examples of typical development. So you're able to see the contrast.
Yeah.
It'll give you an example of typical development with appropriate play, and then we'll show you one with red flags. So you're able to really contrast the two, which is really nice.
Yeah, that's really great. So some of the tools that are being used out there, so let's say we're working with a family, and we'd have a conversation with them about, or they've had a conversation with us about the fact that they know that there's some red flags for autism, or there are red flags for something. They know the development's not typical, they have questions, they have concerns. One of the things that a lot of pediatricians are doing now is called the MChat. So those of us with toddlers, we see it usually at 18 months, 2 months, and then sometimes at the 2.5 month visit. It's the modified checklist for autism in toddlers. It's usually given anywhere between the 16 and the 30 months, and it is used to really just assess a risk for ASD. It's not used to give a diagnosis. It's used so that a pediatrician can be like, there's something not right here. We need to probably do some further testing. There's some red flags standing out on this. It's also something that if you go to the mchat.org, if you want to look at what it is, it's there, and parents can do it online. A lot of pediatricians lately that are getting this and they're doing it with a family and red flags are coming up on it, they're actually sending it to early intervention with the referral, which is so helpful for us. So if you know a family that's had this done and they did raise red flags on it, if they make a referral to early intervention, it's a really nice thing for us to have because we can start to see where the concerns are right off the bat. The next thing that we will use that a lot of our developmental pediatricians have liked to do is a STAT, and it's a screening tool for autism in toddlers and young children. Staff do need to be trained in this in order to administer it, or doctors would administer it. We do have 2 staff currently here that administer it. This is going to be used for kids that are in that 24 to 36 month range, and it's basically after what we call, so if the MCHAT comes up with 3 positives, it's called a failed MCHAT. If we got one of those where those 3 things kind of lit up for us, we would move on to this. All this is going to tell us is whether or not they need further assessment, because you can get false positives on the MCHAT. So, and we've seen false positive with kids that might have like a sensory processing disorder. And so they're so busy all the time that the eye contact's not quite there. Some of those stimulating behaviors might be there. Some of the joint attention might not be there. So we've definitely seen some false positives with that. So this is kind of like your next step tool, which is great. And this one at the end, you sit and give feedback, and it tells you whether you need further assessment from a doctor, which is good.
And I think one of the things to point out about the MCHAT for anybody who's had the MCHAT asked of them with their toddler, a lot of it is, it's a questionnaire.
Right.
So I think a lot of times we always want to be sure that parents actually understand the questions that are being asked. So I just always encourage parents to ask, what does that look like? Or what do you mean when you say that? Because again, a lot of the false positives come because their reporting is just off, because the parent didn't really actually understand what the particular question meant when they're saying joint attention and things like that. So I just say, ask, say, what does that look like? Like, give me an example of what that would look like in a 2-year-old. That way you're answering the question a little bit more reliably, I guess would be my...
Right, and your choices are yes or no. So it's, we do also get families that will say, well, sometimes she does that, but not all the time. Well, my choices are yes or no. So if you put one over the other, it could light up differently based on what answer you chose. So that's why you want to kind of refer for further evaluation. And at the end of that one, that would let you know whether or not you really need to make a referral, like an outside referral to a pediatrician, to a, one of the CNDCs or something around here that you'd want to have families look into. So those are just 2 of the tools. Those are the 2 tools we're most familiar with, because that's what we use in-house here. And it's what the people we work with outside of here, when we refer for outside referrals, have asked us to use to give them information. But there's plenty of other things out there for screening. So we also will check in sometimes with doctors and say, we've made this referral to you. Is there something else that you would like for us to do? Is there some other tool we can give you? Some really just want a copy of the IFSP that we've done. So the family service plan that's in early intervention, they would like a copy of that so that they can see what we've been working on, what made us think that this referral was necessary. So we've really tried to partner with people to make sure that we're giving them the information that they need. So these are some of the options for further assessment. So we have the resources here, right? Okay. So Jen will pass around a resource form for you guys afterwards. These are the different places that are going to do some kind of further assessment for you. So we have neurodevelopment centers. So in Rhode Island, we have the CNDC right at Hasbro that will do a full evaluation on the child. We also have Pawtucket Memorial does a full assessment too. They will also do genetic testing just to see and rule out anything else that might be going on. They do a really nice full assessment of all areas. So when it comes back, it's not just, no, we're not giving a diagnosis of autism. They may have other things to look at, another road to go down, which is really great. Clinical psychologists, developmental pediatricians, which is different than a regular pediatrician. They actually specialize in development. Behavioral pediatricians, children's hospitals, child neurologists, and child psychologists. So what we'll hand out is just some local resources that we have here. So one of them is the Center for the Study of Children at Risk at Brown University, and we work with Dr. Scheinkoff over there, if you've ever heard of him. And a lot of times the referrals made from, we'll sit with the family and say, these are the 8 places or so that will do testing. Where would you like to go? We've advised that if you call and there's a wait, you might want to call the next one and the next one and the next one till somebody calls you back, because there is a long wait at a lot of them.
And on every wait list, that is my one advice to give to families: call them all, because somebody's going to call you back sooner. Get on cancellation lists. Our staff tell us. Brown Center for One has a cancel call list. So if you tell them, put me on the cancel call list, sometimes you only get a 24-hour notice, but if you're kind of flexible and I get the call and I can come tomorrow, then that's great because the wait is really long.
Right,
So.
absolutely. Hasbro, I mentioned Hasbro has the Child Neurodevelopment Center. They, again, will do a pretty full assessment. A lot of times they will do genetic testing as well. And then Memorial Hospital will do the pediatric neurodevelopment, so it's like a nice full assessment. And I've heard from staff that the feedback has been really good. They'll really sit with families, they'll give them the feedback. It's not just your test results, it's this is what we found, here's some next steps, let's find you some resources, let's kind of get things going. So it's not just kind of like I'm going to drop a bomb on you of all this information and walk away. It's let's work together. And so we've encouraged our early intervention staff for one person to go with them to those visits, because then they can also help come up with new strategies and stuff to work with the family and really kind of keep everything moving. And then there's also a list of developmental pediatricians on here that are in Rhode Island. We've also sent families up to Children's Hospital in Boston. They diagnose earlier in Boston. They seem to diagnose children around 18 months to 2, where we seem to get more of that late 2, 3 around here. They are very versed in the work that they do up there. Actually, one of the clinical psychologists who heads up one of the departments actually came and talked to our staff here, and was really great about helping us work with families and work through what does this all look like, and walked through the steps of it. So if insurance does cover, you'd have to make sure that that was an option for you. They're great. They're pretty quick. They have, what is it they call the quick?
They have like a fast track program. So when you call for intake, they'll actually do a series of like a few screening questions. They want the age, and depending upon the age of the child, there's a fast track in. If you're like the 30-month and over, they're like, you need to come quick, versus if you're 18 months, they kind of put you on a wait list.
I have a little girl that just got diagnosed, Boston too. She's a little over 2. She turned 2 in April. She was diagnosed in September, and now she's getting 30 hours worth of therapy.
Yeah.
Behavioral.
Yep. So it definitely, what we've heard is that once that diagnosis is there, more doors open up. So you're able to do more with Katie Beckett Insurance if you need more insurance to cover. It opens up, and we'll give you a list of ABA in the area as well. It opens up the opportunity to do that, the behavioral analysis.
What is Katie Beckett?
Katie Beckett is like a Medicaid, it's like a secondary insurance, like a supplementary insurance. So it's something you have to apply for. You have to make sure that all your paperwork is in line to get it, and it's something you can apply for. So if your insurance can't cover the cost of everything, you might be able to fall back on this one.
They do have a website, and the application is online for Katie Beckett. If you just literally Google Katie Beckett, it's KITIEBECKETT. It will give you all the information, the criteria, and I love that the application is online because we can just print it and bring it right to families. So you're welcome.
Absolutely. And just so a little bit about what the referral looks like. So obviously you make a referral, you get put on a list, somebody will call you. There is a couple different sessions that usually happen. So the first session that happens is usually an intake. Where they'll sit and kind of get all of the information from you. Like if the pediatrician has sent things over, then they'll get the information from the pediatrician. They'll ask you lots of questions. It's kind of like a background informational session. They may or may not do some of the testing at that point, depending on how long that intake process takes. Or they might send you for some blood work or things like that, and then they may have you come back to do the evaluation piece of it. And then after that would be your feedback. So, we try to prepare families that it's not just going to be one session. It's going to be several sessions. And again, bring who you want to those appointments. Don't feel like you can't bring people to support you or to be there to kind of help go through. Because I'll tell you, a lot of our families, they start the feedback session, and after they hear the first 2 sentences, they've shut down. So they're not hearing the rest of what happens. So to have somebody else there that's going to listen and then kind of walk back with you after that is really important, because it's really hard to hear that news, and it's really hard to hear, for some families, it's hard to hear that there isn't a diagnosis, because then what's going on? What is wrong? Like, now you're telling me my child doesn't have autism, so what is happening? Because I still have all these problems, and now I have nothing to even label it with. So what's happening? So we've actually seen that to be as big as a concern as actually getting the diagnosis. So it's interesting because it can kind of go either way. But somebody to sit there and actually sit and listen and reflect and actually come back with you after to say, so this is what I heard. I'm not sure what you heard. And they will usually give you a written report to go with it. It may not be that day. It may be later. You might get it in the mail, or you might have to pick it up later. But there's typically a written report that goes with it as well, so that you have that information. We tell anyone that's going to be transitioning out of early intervention to a school department to bring that with them to those meetings, because it's important to have all of that information when you go. And for us, it's not our report, so we can't bring it. The family has to bring it to that meeting.
Could we ask those of you who've gone through, as you just mentioned, you've gone through this process, do you have any advice to share with families, or, things like what are good questions to ask, or things you learned from it that you would do over? Anything you want to share, any of you?
Well, I've been doing daycare for 27 years, and I've had sensory, autistic, and this is probably my second autistic child. And I found all my parents were in major denial, major. So I think people really should do something with the parents that are in denial, support programs, anything to help the parents, because when they do hear the news, it's just so painful.
Yep.
And you don't want the child to fall through the cracks.
Right.
Because I have one family that she had a little boy in my daycare, and the therapist was there, and I kind of said, I see some red flags. And so my daughter's a social worker, we got the teacher, we got everybody, and we all said, we can get you funding, and we can help you with the paperwork. And we had her there, and she said no. And to this day, he left. She had a second baby. She wasn't upset with me. She left. He's in kindergarten, and in kindergarten, they wanted to get him tested, but because it's not a state law that you don't have to go to kindergarten, so whatever. So now he's in first grade, and now I think what's going to happen is when they do the comprehension, that's where they're going to get to be tested. So he fell through the cracks. So I think that's a big thing. The parents are in denial.
Yeah, and it's a hard thing. So you figure, you have this image of who your child's going to be, what they're going to do, and then somebody comes up to you and says, this child's not going down the path you thought they were going to. That's not easy for any parent to hear. That's whether it's autism, a developmental delay, anything. That's not easy for anybody to take in. So I know a lot of times as professionals, it's hard. We think it's hard because it's like we're trying to get you there. If they're not ready to be there,
We respect that.
we have to respect that. As a parent, believe me, my child's been in early intervention as well. Like she had a speech delay, and it's really hard to hear someone say, yeah, you're right, she's not doing age appropriately what she should be doing. And that's hard for anybody to hear. So it's like we can offer a conversation, we can offer resources, we can tell them what's there when they're ready.
Yeah. But the flip side, you feel bad for the child because he's not getting the care they should be getting, because it's so important to get that help when they're little, really.
Right, and you're right. The research does support that the earlier the intervention, the better outcomes for children with autism.
Yes.
So we see that as being an early intervention, that we do want to get at it so early because we know that the outcomes are better. But we also, fortunately, respect the parents, path. It is their decision. It is their child. So we understand when you're ready to acknowledge it, you're ready. We're here to help you, but that's kind of.
And I think you really just had Asperger's autism, but they don't diagnose that now.
Correct.
But
Right. So, and I think, it's one of those things too where, the parent is going along and things are okay, and then, we're talking about these are the things, but a lot of times in autism, what, you hear from pediatricians when you go for your appointment is everything's going okay, and then you hit a certain age and stuff can go backwards. And that probably is the hardest autism. Like when you start to see red flags at 9 months old, 10 months old, parents start to think, okay, something's up. But when you've had a child who has hit every milestone and they've gone along and everything's been okay, and then they stop and then they go back, that's so hard for anybody to watch.
I agree with what she said. When my finger was diagnosed, my daughter did something I didn't want to deal with it, and I'm like, no. And so finally I said to him, okay, I'm going to get a shirt that says it's not about you. I'm going to give you a week to grieve, and then you're going to deal with this, because it's not about you anymore.
Right.
That.
Yeah.
And when they looked at it that way,
Yep.
then it made sense to them.
Yep.
They needed the time to grieve. I gave them a week. A week later I came back and said, okay.
Time's up. Yeah, it is a grieving process, though. You definitely have to respect that that's definitely a grieving process involved in that. This is not the child I thought I was going to have. Some of the things I thought that they would be able to do, maybe they're not going to be able to do, and that's okay. Because I'm going to worry about what I can do and where we're going to go from here, and I'm going to, and that's how we're going to go. Exactly. So it's about what support is there, and They're lucky to have you to be able to support them. You know what I mean? Like, that's what you want to see happen, is that they have people around that will help support and get them through. This is a really tough thing, you know? How are you going to get that support? So, you know, our hope is that by preparing families for what's going to happen, you know, some families would go to this and think they were going to get an answer the second they walked in, and, you know, that's not fair. So we want to prepare you. You know what? We're going to go in today. It might be a really hard conversation, but we're going to start to talk about the things that you see. You're not going to get an answer today. So if we go in with that in mind, it's not like they're like disappointed when they leave, you know? And we say to them, we will sit there with you. If you want us to say nothing, we will say nothing. Just know we're there. We are there to support you in this, and we will help whatever way we can, or we will back off if you tell us to, but this is what we're here for.
The good thing now is that there's so much to offer to help those children that they will be okay.
Mm-hmm. Yeah, we're very lucky. There is a lot of support.
Like, I
Yeah,
have a cousin
yeah,
that
well.
her child has it, and she would run away. Like, so my mom, like her grandparents couldn't take her to the mall, but she would take off. And she got a social coach and took her to the mall
Yep.
and showed
Worked
her
through
how
it.
to behave.
Yeah.
And she was only 4.
Yep.
And then she would come back, and she was able to go, because my aunt loves to shop, so she would say, oh, you know, so-and-so said I have to stay with you, I have to walk with you,
Yep.
I have to do
Yep.
this, you know, so she's, and, you know, she's really thriving now
Yeah.
at 7.
Right, and I think, so that's a lot of what early intervention will do. So if we go in and your goal is to be able to go grocery shopping with your child, guess what we're gonna do once a week? We're gonna go grocery shopping with you. We're gonna walk you through that process. And if we only get to aisle 1 today, that's okay. Our goal is to get to the end aisle by the end of it. So we're gonna do it. And we're gonna do it with you, and we're gonna figure out how to get this to work. Because if that is gonna make your life easier, because you have no one to watch your child and need groceries, we're gonna do that. We're gonna figure out how we get that to work. And whether it's after 3, we get a social coach or someone in to help you, we're gonna figure it out. There are definitely things out there that we're gonna be able to do. We're gonna take like a 5-minute break.
Okay, so we're going to talk about evidence-based practice. So evidence-based practice are the interventions that researchers have shown to be effective. There are actually 27 classified interventions shown effective through scientific research. We're just going to talk about 5 or 6 of them that are relevant to the population that we deal with from the 0 to 3. Some of them go up to preschoolers, 3, 4, and 5s will use them, but we just really want to focus on the ones, you know, in the early years. So the first one is prompting. And prompting is any verbal or physical help given to a toddler that assists them in engaging in a specific skill or behavior. And then we're going to talk about 2 different types of prompting. So the first one is most to least prompting. So using the most amount of prompting necessary to get the child to perform a correct response. So as the child provides proficiency in the behavior or task, then you less the prompting. Usually this begins with physical prompting, then verbal prompting, and then natural cues. So an example of that would be, let's say, a child who, Claire used a good example today of shoes, for instance. So it's really thinking about, you start with a lot of physical prompting, you want to move the child over, let's go put on your shoes, let's go put on your shoes, always touching, walking over. And then really kind of dropping it down to just verbal cues. Let's go get your shoes without actually having your physical hands on them to kind of guide them and move them over. And then just natural cues, go get your shoes. So really just kind of decreasing the amount of prompting, you know, that you're giving. Start off really heavy in the prompting and then guide it to least prompting.
One of the other examples the staff gave today, which was great, was you're doing a puzzle, and so it might be like a hand over hand, right? So you're helping them do the puzzle, you're physically helping them put the pieces in, and then you want to just tap them. Tap their elbow, and they put it in. And then you want to say, okay, put the piece in, and with no touching at all. So you're going from like the most help possible to really just backing it off through the whole, just the verbal piece of it.
And then on the flip side, we do least to most prompting. So that is starting with the least amount of prompting, that's okay, natural cues, and then go to verbal prompting and then physical prompting. So there's really 2 options that you can utilize. And the next one is time delay. So time delay is the parent would give the prompt to the child and then wait to see if the child responds, and then give the verbal prompt again with the physical prompt to go along with it after waiting a few seconds for the child to respond. It is to fade the use of prompts over time to help reach the target behavior without having to overuse the prompts. So again, the shoes is another example. So you can really kind of say, you know, go get your shoes, moving them over, wait. And we talked about today, you want to have a realistic wait time. We talked about, like she said, it's like milliseconds. People expect like a response immediately, when you really should have, like you should say, I'm going to wait 5 seconds. So it's go get your shoes, and you really have to count it out and wait 5 seconds. Go get your shoes, wait 5 seconds. Then you can kind of move them. Go get your shoes, you can physically prompt them over. So really just thinking about, you have to be consistent with the time delay and the expectation, because we're just always such a society that's on the go. So it's like we give a directive and we expect an immediate response. But with time delay, you really have to stick with it. I'm going to give them 5 seconds to process this and then go ahead and move towards what I'm asking them to do. So just kind of thinking about that when you're giving the request.
Because you got to give them time to process what you said.
Right. So the next one is naturalistic intervention, and it uses the child's natural environment and interest as motivation and reinforcement. It is intentional in trying to achieve the child's goals, and it is child-led and serves as an opportunity for teachable moments for the child. So you want to use something in the child's natural environment that interests them in order to get them to do whatever it is you're asking. So one of the examples is if you're using this as a learning opportunity and you want something out of it, and let's say you're trying to sit with, your 2-year-old or 3-year-old and you want to just talk about colors. You want to use something that's of interest to them. Get out all the blocks. And through this natural play back and forth, you can talk about the colors as they're playing. Look at that blue block. Look at that red block. Cars is another opportunity. Something that interests them, that they're motivated by in order to kind of get the end result. You want it to be child-led. Use something that interests them in the environment to kind of adhere to the end result that you want from them as a teachable moment.
So I think it was cute today. We had one of the staff said to me, we said in the training, she's like, so this little guy loves cats, and we were trying to get him to throw a ball. So they were able to get the cat to toss the ball back and forth with him and play. And she's like, he started to say ball, he said cat, he said another word. The mom was like so excited because she had never heard him say any of those words before. She's like, the cat's always there. I guess the cat's playing with me every time I go now. Because it's very motivating and it's part of the natural environment. And she's like, thank God the cat decided to pretend with me. But she said it was so easy, like the cat's gonna always be there. That's something mom can do when I'm not there. It's not like I'm bringing something in and then taking it away. Like it's something that's there that she can use, and as long as the cat cooperates, we're good to go.
Yeah, cat was catching the ball and everything, so that's perfect.
She's training the cat too.
So the next one is pivotal response treatment, which is providing intervention to infants and toddlers in pivotal areas that will result in collateral effects in a related behavior, and it will help reach out to areas beyond what is being taught. So it works on all areas and is carried through and embedded in other areas. So we'll talk about the different pivotal response treatments that you can have. So the first one is multiple cues. So children don't overgeneralize but can pick up on other characteristics that distinguish one thing from another. So what that means is a child may recognize a familiar face, a familiar person, by limited detail. So say, for instance, they recognize their grandparent because their grandparent has on glasses. A piece of jewelry, a specific gesture, or something that their grandparent always says to them or any other family member. But if those details change, that child would not be able to recognize that person as their grandparent. So if the glasses were off or they didn't have on that specific bracelet she always has on, that's how they're identifying by the multiple cues, not necessarily recognizing that that's actually my grandmother. I just know that because she wears these 2 bracelets every time. So if those bracelets are off, they may not recognize that person. So the next one is motivation. They will have a higher response to complete tasks if they're motivated. So in general, allowing the child to make the choice of the material that you want to motivate them by is going to have a higher success rate. It again, goes back to, motivate them by something they like. The same thing with the cars or the blocks. If it's something that they prefer to use, then use that in order to get them motivated to complete the task you want from them. The last one is self-management, which is shifting of the responsibility from the parent to the child. And they'll learn to monitor behavior so they can function in different environments. And what that refers to is being able to self-regulate your behaviors. So not having to rely on the parent. The shift relies from the parent to the child and expecting the child to be able to self-regulate their own behaviors without the parent having to consistently regulate that child's behaviors for them. So that is pivotal response treatment. The next one is reinforcement. So reinforcement is almost always used with other evidence-based practice. So one of the things to kind of note when we talk about these evidence-based practices, not a lot of them actually work in isolation. They're all pretty embedded within one another, so they never are really just kind of like a standalone evidence-based practice. So there's 2 types of reinforcement. The first one being positive reinforcement, which is when the child experiences something he or she likes right after using the skill or behavior with the likelihood that they will now repeat the behavior. So essentially we know what positive reinforcement is. You do something that's expected of you, and we give you something in return to reinforce the behavior consistently over and over again. So they learn that this is the behavior that's expected of me, and if I do this, I get this that I really like.
So that's something you really do with any 2-year-old?
Correct.
whatever?
Positive
So-
reinforcement works for really anybody,
so
even
if you
adults.
have somebody if you have somebody with, like I'm potty trained.
Mhm.
So when they pee on the potty, they get an M&M. Well, after like 2 months, that just goes away. They don't get M&Ms anymore because they're potty trained now. They don't
Right.
even ask for them. So with someone with like autism, would that like positive reinforcement have to be like more than that? Or
No, because they also, so in that particular instance, let's say, that would be paired with, what was the first one we just talked about with decreasing? The prompting. So you want to go from most to least. So realistically, that's essentially what you're doing. You start off with this heavy positive reinforcement. You get an M&M every time you go to the potty. But then you have to sort of decrease it because you really, for a child with autism, don't just want to pull that away and there's nothing there anymore. Like you want to decrease it, again, like the most to least prompting.
It's every other time, and we're
Right.
every third time. And
Right.
then one of the things they talked about today is like, the kids want the food, but they can't tell you they want it. So what we work on a lot is that picture exchange. So if you give me the picture of the apple, I'm going to give you the apple. So you got positively reinforced for giving me the picture. You got what you wanted from it. So it can be used that way too. So when we ask kids to make a choice between two things, and they pick the one they want, they get it. You're getting reinforced for getting what you asked for. So.
And on the opposite end is negative reinforcement, which is when you take away an object or an aversive situation that the child does not like when the toddler does the skill or behavior. So it's the example we talked about today with the feeding, for instance. We have some staff who kind of use this feeding protocol, I guess we want to say, with young children where they're children who are picky eaters. So we're really trying to work on getting them to eat different types of foods. So there's kind of like this process where they allow them to take the food, kiss the food, and throw it away. So really that's removing what they didn't like, but they are still going through with the expected behavior that we wanted them to do, which was just bring the food to your lips. We know you don't like it, but you can remove the situation. So it works. I mean, negative reinforcement doesn't really happen as much as positive reinforcement because I think people just sometimes don't want to have to take away the thing that the child doesn't like because they don't really know what to do with it next. But really, it's just getting them to do the expected behavior or skill. And there really isn't anything negative about it. It's not in a negative connotation. It's just called negative reinforcement because you're just going to take it away. It's not
negative to them
positive.
and you're removing
Right.
it.
Exactly. So the next one is modeling. And modeling relies on adults or peers providing or demonstrating a target behavior. This is often combined with other strategies such as prompting and reinforcement. So there's two types of modeling that can happen. There's video modeling and what we call live modeling. So you want to model the target behavior consistently that you're expecting from them. Our staff use the video modeling a lot with some of the children who have social communication disorders. It's a good option to also have for parents. So when they're in the classroom, for instance, and let's talk about something like a shape sorter. They video the exact skill that they want done, so just kind of like their hands are there, and they're videoing exactly, or modeling, what we want to call it, what they want done. This one goes here, this one goes here, this one goes here. And then they show the child the video. And then the child can model exactly what the teacher did. This goes here, this goes here, this goes here. We've seen it done with shape sorters. You can, again, live model it in front of the child, what you want from them, or the video modeling, which I just find, because everybody pretty much has smartphones these days with video capability, video modeling is just, it's great. You can really video model anything you want, any behavior you're trying to demonstrate for a child or an adult is really effective when they're able actually to visually see what you want from them rather than just giving them verbal instructions. And I think this is
So early intervention is birth to 3 is how long the program in Rhode Island works. There are some programs that go longer. So what we start by telling parents that you're only in the program until you're 3 anyway, because we got to prepare them ahead of time that we're going to be out of the picture by their 3rd birthday. But we start the process at 27 months. So at 27 months, we start to have a conversation that, again, we're only in the program until you're 3 years old. So let's start talking about what's going to happen after we're done. If a family agrees, what we will typically do is make a referral to that family's local school department. So if you live in Providence, we refer you to the Providence School Department. If you live in North Providence, you go to the North Providence School Department. We'll work with the family to make a list of the child's strengths and needs in the different areas of development. We call it here a transition summary. So we put it together for them, and it's for the purpose of transitioning them somewhere else. If the family doesn't need to go to a school department because the child's skills are functioning enough that they're in a regular childcare, we will still do the transition summary because we want wherever they're going to be, so if they're going to go to a new childcare or even the one they're in currently, we still want them to have that. This is what this child is going to be leaving with. These are their strengths, these are their needs, and that way they have got a lot of those things written out and spelled out and already can start planning for those things ahead of time. So the next part would be the school will determine if the child would need further assessment. Click ahead, sorry. But before determining if they were eligible for services. So every school department does this differently. Sometimes if we've recently done an assessment in early intervention, the family has recently gotten a diagnosis from a doctor or pediatrician, you've recently had an evaluation done somewhere else, they may not do anything else and just take what you have and go along with the process and decide if the child's eligible. Sometimes it can be from last week and they're still going to want to do their own tests. So it depends on the school department that you're working at and what they want to be looking for. Sometimes they'll only test in one area. Sometimes they'll do a full assessment. So that really just depends on the school department and what they want to do. But anything you do have from a previous assessment is very helpful in helping that team make a decision about the child's eligibility. So you want, if your child's in early intervention, you want to bring all of your early intervention paperwork. So we would send that over if we've made the referral. So they would have all of that already. So any outside evaluations that you've had done, again, that's the parent's responsibility to bring because it's not our document. We can't send it over when we send over everything else. And then we would give you from early intervention, you get a completed summary of everything the child's doing, strengths and needs wise, that would go with you to the school department. So we talked a little bit about they might decide to do their own assessment. So sometimes we haven't assessed a child in 6 months, or the last assessment they had is 8 months ago. They may decide to do a current one just to see where the child's strengths and needs are still at that point. When they write an IEP, so an individualized education plan, it's gonna look a lot like what we've done in early intervention, where they're gonna look at the different areas of development and write strengths and needs. So the nice part is if you've kind of gone through that process in early intervention, this is not a brand new process. It's more about the child's academics versus where we will include the family in our plan. Theirs is more strictly about the academics and areas of development. Once the child is determined eligible or not, you would either write the IEP or we would find other resources for you. So if the school says, yes, they're eligible for services, those services can look like a classroom. It can be a half-day classroom. It can be a full-day classroom. It can be an integrated classroom, which means there's children with and without IEPs in the same classroom. It can be a self-contained classroom, which means it's just children with IEPs in that classroom. So it looks really different based on whatever school department you have and what they offer. If you want questions about certain towns, I can give you a little bit more information, but it really depends. Like Providence has a ton of classrooms. They have a plethora of whatever services the kids need. There are other school districts that don't find that they do well with children who have a wheelchair because they don't have the accessibility that they need. So we'll get some of those referrals here because we have a handicapped accessible building. So I think it just kind of depends on what they have and what they feel they're comfortable offering. A lot of schools don't have a teacher of the deaf. So we'll refer to the school for the deaf, or we'll refer to Orchard Farms or somewhere that's able to provide the services that the child needs. So if they're not able to provide the services in that local school department, they would send the family out to look somewhere else to figure out what would be a suitable placement. So that's where we come into play because we're considered an out-of-district placement. We have children from ages 3 to 22 with IEPs in this building. Up through grade 6, we are integrated, so we do have children with and without IEPs in those classrooms. After grade 6, it's just students with IEPs, but we do a lot with the older kids of like life skills, so trying to teach them what's going to be like when you go out there. We know Cornerstone is another one that does the same kind of services we do. So they would have to determine whether or not they felt they had the skill set to service the child in district. If they don't, they are responsible to find a skill set out there that would fit the needs of the child. Does that make sense? If they're not eligible for school services, then the early intervention provider would give other resources for the family if they felt further services were needed. So that's when we would recommend an outpatient program for maybe outpatient speech or a PT or OT, or we would recommend HBTS, or we would recommend ABA, or whatever is out there based on what we find the skill level is of the child. So it would just kind of it would be what the parent's looking for. A lot of times the other services a school department will offer was what they kind of call walk-in services. So you might go for speech therapy twice a week for half an hour. The parent has to bring them there and have the services there. We're lucky enough that we also have some preschoolers here who have that service. At like 3, they have speech. The speech therapist from like Providence will come here because there's several children that need it. And so they'll come in and see a couple different kids at once and then go back to the school department. So it kind of depends on where the kids are, what you'll get. So any questions about services, transition? Yeah?
Yeah, I don't know if I missed something, we should take a step back.
Sure.
How do the children, toddlers get referred here?
Toddlers get referred?
Well, you said earlier intervention. How do they
Yep.
get referred to you?
Sure.
Pediatrician?
It can be anybody. So anyone can refer to early intervention. So a parent can refer, if, you can refer, like as a provider, you can refer, anybody can refer to early intervention. Obviously you'd want to make sure the family knew you were referring them, but we have a referral line here. So you would call,
So basically, if they're not meeting some
milestones, yep.
So then when you said when they go for the assessment, you're seeing them, but you're not sure what it is that
Right.
is on.
Right. So we may know, but we can't diagnose. So if you can make a referral here or any early intervention in Rhode Island. So now there's 9 of us because a few of them have closed. So there's 9 of us all together. So we always give parents choice. Wherever you would like to go, you can choose. So, but we have a referral line here. You would call into the referral line, say, I'd like to refer this child. So any child birth to 34 and a half months. After 34 and a half months, it goes right to the school department. You would call, we would send out someone to do an intake, so much like you would if you were doing a referral outside. We come in, we find out what's going on, what are your concerns. Like parents will say, well, my child's not walking yet, my child's not talking yet, the pediatrician said I should call. So we would go back out, 2 of us professionals, so Jen and I are both educators here, but we would go out with a therapist. So if it was a speech delay, we'd go out with a speech therapist. If it was a motor delay, we'd go out with a physical therapist, and we would do an evaluation. So the evaluation really just determines whether or not you're eligible for early intervention. So yes, we see a delay somewhere. Or there's something that has happened that is causing a significant impact on your functioning. So maybe mom passed away, maybe they've moved 6 times because jobs keep changing and this child's functioning is just kind of being impacted from all the things that are going on. So we would qualify under that as well. So then we would figure out what the goals for the family are and put services in place to help with those goals. And then we would stay in. We do updates every 4 months. We kind of check in. We'll do new screenings, kind of change goals as kids accomplish things and write new ones. And then we just kind of go from there until we would transition out at age 3.
And autism is a single established condition in the state of Rhode Island, so one of the other ways you can qualify for early intervention services is a single established condition, which is a diagnosis. Things like Down syndrome, a lot of chromosomal disorders, prematurity, low birth weight, but autism happens to be one of them. So some children we do get come in already with a diagnosis, which is wonderful that they're getting diagnosed that early. Yeah. And then it sort of makes the process much easier because they can come in and the interventions are happening immediately for them because we don't need to go through all of this testing. Yeah. Just, kind of come in that way. So that's nice. But that's an automatic qualifier for early intervention in Rhode Island. So it's great.
And then my other question is, when the therapists go out, do they work with the children with personal care? Because in a pediatric dental practice, we don't see that, like that early. And it's difficult for most toddlers to get the teeth brushed, let alone when they have all these sensory issues and stuff. And I don't know if any personal care, haircuts, any of those types of things are addressed.
Right, so it would depend on what the parent set for goals. So if the parent's goal is they want to bring them to be able to get their hair cut, then we probably would send an occupational therapist out to work on some of the sensory stuff that's causing them not to be able to get their hair cut.
So unless the parent is educated that your child should be going to get their teeth cleaned, it's not going to be right. So like in other words, you're not setting parameters for them. You're kind of just meeting their,
Well, that's early intervention. Like, we're not essentially a social service program
Yeah.
where, like, that's early Head Start, where they go in and they actually coach families on, you should go to the dentist, you have to have your immunizations. But we address family concerns. It's a family-driven program. So if the family comes to us, like Casey used the example of the grocery store.
Yeah.
So it's just to say
Yeah.
it hasn't
Yeah.
happened.
Yeah.
But if a parent were to say to us, I really need to figure out how I'm going to get, Sally's haircut because it's just impossible. She doesn't sit still. Then the OT would be like, let's go and try it. So it's not to say it wouldn't happen. It just has to be parent driven and requested of us.
Yeah.
We just don't get to decide for families what the goals are. The family drives the bus and we just go along and support them.
But we have had parents say, I can't go to the dentist because she won't sit still. So, or we can't get her to go to the dentist because she's afraid to have anybody in her mouth. So then we've got an OT or a speech therapist out there trying to figure out what sensory things can I address to make that easier for you. And sometimes somebody will even go with them to the appointment. We have staff that go to doctor's appointments. We have staff that have gone to the dentist. We have staff that have gone to the beach because they can't stand the feel of the sand on their feet. We'll kind of go and support anything that's going on. If, we have a lot of families that'll say, I just want to go out to dinner. Like, I can't go out to dinner because my kid is off the walls. I don't know what to do. So we'll practice at home first. And then sometimes maybe we will meet them at McDonald's and figure out if we can get them to sit through a meal. So, I mean, it's really, if that's something that they're concerned about, we certainly will jump in and help them figure it out. So, and some of it is we've got to do some techniques at home. I had a kid who didn't like his haircut. So the OT would help me figure out brushing. We did brushing protocol to make sure that sensation didn't bother. It was the sensation of the hair like falling down and hitting him. He hated it. So it was like she gave me the brush and said, brush him. That will help him get more used to sensations. And then when the hair falls, it won't bother him as much. Took a while, but it did work. So, but for me, that was a concern because I'm like, every time I take him to get his haircut, he loses his mind. Like, help me figure out how to walk through this.
so is every early intervention program parent-driven?
Yes. So it's supposed to be, yes. So what we use is called the coaching model. So the model is to go in and coach families on what to do so they can support their own child when we're not there. Because if I come into your house twice a week for an hour and I work with your child and not with you, what are you doing the other 5, 6 days of the week? Those hours I'm not there, right? So our goal is really to go in and show you how to do something, let you try it, and then we leave and you try it out for the week or 2 weeks that we're gone, and then we come back and check in. You might say, none of that worked. You gave me 3 different things, nothing worked. Okay, great, let's try 3 more things today. And what we found is back in the day when it was more of like, we came and worked with the child, we left, those parents were at a complete loss after we were gone. Or they were out in the kitchen doing dishes and didn't even see what we were doing, so there was no way for them to do a carryover piece to it. So you came back and they were like, well, they're still not talking. You're like, yep.
And the data shows, the research shows that the intervention actually happens between the visits, not at the visits. It's our job just to coach and empower families to do this carryover on their own. We're there an hour of the week. I mean, those parents are there with their child, the rest of the time. So the techniques we're teaching you, we're modeling for you, we're showing you, you do every day with your child. And then that's supposed to build your capacity and then start to see, some growth.
I have a question. I have a little girl, she has autism, and the daycare goes great and everything. She's pretty good, she's getting a lot of help. But every day when one dad comes in at 4:30 to pick up his little boy, she screams, she cries, she has a little meltdown. So then her mom's a teacher and she comes in not 10 minutes afterwards and then she's fine. But every single day she does the same thing. Is that the pattern because she's waiting, or she's disappointed because her mom's not here? I mean, I don't understand.
It could be either, but it is a prime example of, like you said, with like the schedules and the rituals, that just sets her off every day at that
That's
time.
what it is.
Yep.
Well, she knows my mom's coming soon after he picks up, but it's not yet.
It's not yet. She'll stop, but I mean,
Yeah.
she just
Yep.
screams and screams, and she'll just lay on the floor and scream, and but I just.
So something like that, you could do like a countdown timer. So, if you know he's coming and mom comes exactly 10 minutes later,
Yeah.
you could set it up before he walks in with a timer and set it for when mom shows up, and you can say to her, when the red is all gone, that's when mom will be here.
Okay, I'll do that.
So something like that, or you can set a timer when the ding goes off, mom will be here. So we're lucky enough to have some adaptive stuff here, which you can actually order those on Amazon because that's where we've gotten them from.
Okay, good.
But for them, it's a visual thing. Like, so if the key is if you know something is going to happen, if you can do it before it happens and
Yes.
prepare them.
Now, have you ever had him not
It's a
or
great
not
idea.
see him? Is it him?
It's just, I can't do it because it's pickup time and
Yeah.
it's like,
Yeah, I'm
we're
just
all
wondering
there.
if it's
I can't,
him or
like I
if
had
it's the whole
yeah.
mom.
Well, they come in, but it's a big room, a kitchen, and then another room is a table, it's down the basement, they all come in. But everybody's getting ready to pick up, I just
Yeah.
can't come in the other room, I feel
Just
Yeah.
curious
doing
to see
that.
if it was him.
Yeah.
Or,
Yeah.
Right, like if you kept her occupied with something else when he came in, would she not notice?
Right.
Like,
She
right,
would
it's
notice.
a very busy time.
She
so,
would notice,
yeah.
she did,
Yeah.
I've tried that. But,
Yeah.
you know, I
Yep.
tried to give her her favorite toy, I
Yep.
tried, no, it's just, she knows.
Yep.
It's like, she can see, like, they got windows, and she can see him coming down, and she can
She
stop.
already starts.
Yeah.
Yeah.
Yeah, so you could try something like that, just, you know,
Yeah, I'm
and,
gonna try that.
you know, just to let her know, like, you know, start it ahead of time before she sees him and kind of says, when this is done, then your mom's gonna be here.
Yeah.
We had a little guy one time, mom came at 4:30 every day. One day she literally came at 4:35 and he screamed from 4:30 to 4:35 because he knew he was supposed to be picked up.
Yeah.
It's just they know. They don't need to know how to tell time. They know when they're supposed to be picked up, you know. Or it's like, I know when snack time's over, my mom is supposed to be here.
Yeah.
Snack time was over and we started to go outside and he was like, no, I don't go outside. My mom comes before I go outside. What is happening? So they're smart. They know. They know.
It's hard to break that ritual. We had a terrible time with drop-off at school, and she likes school, she likes her teachers, but drop-off is just, it's grueling every day.
Mm-hmm.
When you get to that door, it's like, oh, not another tiebreaker here.
Yep. Well,
It's just a ritual.
It is the ritual.
Yeah,
exactly,
it's
yeah.
tough, and it's sometimes we had a little one in the infant room that's really struggling with drop off. So we find sometimes when kids enroll in childcare, like at like what I like to call the height of stranger anxiety. You know, you enroll them at like 13 months, and they're like at that height of oh my gosh, strangers. It's really tough transition to get them in. So we've done some things where it's like we made a box with the child's picture on it, and they come in and they go right to that box, and in there is like 3 of their favorite things that they only get in the morning when they come in. And then after they've kind of come in and situated and calmed down, in there's a picture of the family on the back of the box, and then it's like her favorite book, a soft little toy, and then there's something else in there that she likes. She comes right into her bucket. She knows that's her bucket, and every morning the ritual is the same. She comes in, she gets her stuff out of that bucket, and once she's calmed down, we clean up the bucket, it goes on top of the fridge. She doesn't get it again till the next day. So sometimes things like that are, if there's a routine, it's kind of like throw another routine in there that they can kind of get used to.
And that's sort of, I mean, it's a great ritual and routine for that child, but it also goes into the pot of positive reinforcement, because
Right.
the example is if you can get her in the door and she follows the expected behavior you want, you get something great when you get inside. So they begin to learn, okay, if I do this behavior, she's going to give me this when I get in. So again, it's just kind of like the...
And it's not going to happen
No, it
quickly.
takes a long
We've
time.
seen some kids, it's taken 4 to 6 weeks before something like that will happen.
Yeah.
Yeah.
It doesn't matter. She likes her teachers.
It's
she
just
likes
the
her
ritual.
friends. She's
Yeah.
just gonna cry at the door. That's
Yep.
it. Used to be she cried all the way to school.
See, so now
they
it's better.
Not here.
Yeah.
The poor parents go to work and
Yeah.
so upset. all
Yeah,
the time.
it's tough. And we've had families too, we'll call the second the child has calmed down, and we'll call and say, you know, she's fine, she's not crying. And they can hear, because we're on the phone in the classroom, like they can hear nobody's crying anymore, you know. She's okay. We've sent pictures, like we've emailed pictures and things like that. She's really, like we'll send, especially when we catch them like smiling and laughing with their friends, we're like, see, she really is happy. It's okay.
And I think for the parents, I mean, you know, it's your grandchild, but I think it's important for them to understand, because it is just a ritual for her, and it's one of the characteristics of a child with autism. So it really doesn't mean, like you said, she gets in school and she's happy, but they're walking away feeling like, oh my God, she's so upset. She doesn't like to come here.
Yeah.
So they walk away with like a negative connotation, but they really just have to understand just that ritual for her is just part of the autism diagnosis. So she's really okay when she gets there. It's just that's what she does before she gets
Yeah.
into the door. So they'll kind of feel
And she
a
has
little
made
bit better
progress. If
about
it's
it.
not the whole ride there anymore, at least
Right.
it's better.
Progress.
Did you want to do that real quick?
Yes, so the other page that's in your blue folder is just some information on applied behavioral analysis in Rhode Island, which is called ABA. In Rhode Island, ABA is not part of early intervention services, where in Massachusetts it is. So for us, we have families who come to Rhode Island from Massachusetts and who are requesting ABA services, but we don't provide that. So we provided you with a list of programs that do provide ABA for children under 3 up at the top, and programs at the bottom that do provide ABA for children that start at 3 years old. There are extensive wait lists for all of these programs as well. So it's important that, you know, when we give this information to families, we're realistic to let them know, you know, right now there's like a 4 to 6 month wait list for ABA. And that's really difficult because we do have families with children who do have the autism diagnosis, and they just can't access the services that they want, such as ABA, just because of the way the programs are running
I have that.
The
in
wait
my
list and the
house.
insurance, yeah. Which is
2 hours
great.
each day, each
Yeah,
year.
and that's another thing. ABA, some programs like Groden will do a maximum of 30 hours a week. So we want parents, it's important for us to want parents to they may want ABA, but we want to let them know what that actually entails. It is a lot of therapy, it's a lot of hours in the home or at the daycare. So some parents automatically hear the word ABA when they get the diagnosis and they think I want it, and nobody really explains to them what ABA entails. And then, they get on the wait list and ABA comes out, and then they're at your house for hours and hours and hours, and they want the parent to be an active participant in the sessions, kind of the same way we talk about with coaching. We expect the parent to be an active participant, and sometimes parents just think that ABA is just there to work with the child and they're hands off. So a lot of parents then kind of get turned off by it because they didn't realize that it's a big commitment, ABA. So we just like to, families to know what to expect, kind of before they go that route. But any one of these programs in Rhode Island you can call, and families can get on the wait list. So any questions?
So this is just one last resource I wanted to share with you. So this is a book that we've introduced to our staff. It's called Do Watch, Listen, Say. You can get it right on Amazon. You can get used copies on Amazon too, which is great. It's by Kathleen Quill. And the beautiful part about this book is that if you are looking to do something with a child, so one of the things here is shared attention. So you're looking to try to get a child to use shared attention with you. It literally will go through step-by-step ways to get that shared attention. So, it'll say to you, if a child's not attending, first of all, ask yourself these questions. Is the activity organized? Does the child understand the expectation? So walking you through asking these questions first, but then it actually even will give you role play samples of how to go back and forth and get it to work. And basically they call it a curriculum in here, but it's very simple. Literally they'll list the steps and bullets all the way down on what to do. You want joint attention. Did you call the child's name? Did you wait for them to look at you? If not, try this. If that doesn't work, try this. So it's a really great resource. And in the back, is the back where the checklist is? In the front. So, it's right in the middle. So right in the middle is also a checklist that you can go through. So when we talked about kind of organizing your observations, it's just a basic checklist. It's like yes or no, but you could kind of go through it and say, is the child doing this? Yes. Are they doing this? Yes. Are they doing this? Oh, no, they're not doing that. If you had concerns you wanted to bring to a pediatrician or another professional, you could bring that checklist, or if you wanted to do it with parent, or if you as a parent want to do it with a provider, like if the child's in childcare and you want to ask some of those questions, it breaks it down by social communication, eye contact, it'll break it down into different sections. You can answer the questions, and it's a good way to kind of organize all the things and observations that you're looking at. And obviously, if you have more specifics, you could write notes into those sections. This book is completely, you can copy anything out of it. It's, it says, I don't know, feel free to copy these. This is the checklist right here. It's called an inventory checklist. So it's really nice, and the staff have found it really helpful to do with families. So I find it to be a really nice resource because when you have a child and you're not sure what to do, and you're looking at a specific task or you're looking at a specific area of development, it really will tell you what to do. So it's like these, Do Watch, Listen, Say by Kathleen Quill.
Do watch, listen.
Say, yep.
By who?
Kathleen Quill. Like I said, you can put it right into Amazon. That's where we ended up grabbing it from. So, all right. Any other questions?